So we're here to talk about wound care. We're going to talk about the very basics of wound care. And if you've got any questions, feel free, ask, go for your life. If you've got anything you want to put in from your own knowledge, please add it in there, because we can all share those sorts of things. Because if you're in industry or you've dealt with family members with wounds, you know that it's a difficult thing to do. And they can last for a long time.
Well, there was a lady in aged care, and she wasn't like on the side of my ward. I just went around with the wound care for her. And she just, I don't know if the history of it, but she was paralysed like from the waist down. So she just had a hole, and it had been there forever apparently, like down to a bone, and they just clean it every day. And it will never heal apparently.
No, it's amazing to see. To say they'll never heal, like they can heal those things, but it depends on her immune system, what's causing the breakdown. If it's just a continual cycle of breaking down, building up, they're right, it may never heal.
Yeah, they were sort of saying like it was just dead.
But to stop it getting infected and making it uncomfortable for her is probably the most important part of that. Wow.
And there was another lady with skin cancer, just not the
facial one,
not a melanoma, but the facial one where it's just like eating.
They
couldn't do anything. Can they not do anything?
They can remove it, but it depends on their age.
Which is really old.
And their immune system depends how deep it is, because then they have to give them an anaesthetic. And is the risk of the anaesthetic, could that kill that person rather than the face cancer?
Yeah, well, she was in her late 70s and a little skinny lady with a lot of skin damage all over, but it was like it was just eating.
Yeah, and it just chews away their face,
But don't you remember, before skin cancer became a real, oh God, and everyone has everything burnt off, old people always had, you know, like old people always had the sores and
patches
stuff.
And moles and
and stuff. So it's not new. They're all
they've been around for a long, long time.
It's just that living longer.
And we're seeing more and more because of our exposure to the ultraviolet rays.
Yeah, but they're also living longer, because if they died at 60, it would have just been a spot.
Yeah, exactly.
60s. Now they're going to be 80.
Now young people are even getting it. So, all right, a little video. I like this one.
A wound occurs when there is injury to living tissue. Any break in the skin's integrity is considered a wound. In a clinical situation, classifying wounds can help guide their management. Wounds can be classified according to their healing process. Healing by primary intention involves only the regrowth of epidermis, where there has been minimal tissue loss. These wounds involve minimal scarring and pose a low risk of infection. Examples are surgical wounds, superficial injuries, and first-degree sunburn. Healing by secondary intention occurs when there has been more significant tissue loss. These wounds take longer to heal and have a higher rate of complications, such as infection. They may also result in greater scarring. Examples include pressure ulcers, burns, traumatic injuries, and infected surgical wounds. Healing by tertiary intention involves purposefully keeping a wound open for several days to allow it to drain and to enable infection to resolve. Their edges are then closed with sutures at a later date. Wounds can also be classified according to their colour. Red wounds show the presence of healthy pink granulation tissue, indicating a normal healing process. Yellow wounds contain slough at the wound base. Slough is soft necrotic tissue which can impair healing and can become a potential source of bacteria growth. Black wounds may involve the presence of hard necrotic avascular tissue called eschar. This type of wound is the least healthy, has the longest healing time, and provides a source of microorganisms to spread. Wounds can also be classified according to cause, with each wound falling into two broad groups: surgical and non-surgical. Non-surgical wounds can be further divided into wounds caused by trauma, pressure ulcers, diabetic ulcers, and vascular ulcers. Each type of wound requires a different wound care plan. involving different dressings and wound care procedures. A wound is defined as a break in the skin's integrity. Wounds can be classified according to their healing process, which may be either through primary, secondary, or tertiary intention. Wounds can also be classified according to colour. Red wounds contain granulation tissue which indicates a healthy healing process. Yellow wounds contain slough, which is a potential source of bacterial growth. Black wounds may involve eschar, which serves as a source of bacteria and is the least healthy type of wound. Wounds can also be classified by cause and can be either surgical or non-surgical.
Okay, I recommend that if you want to look at that, it is available on YouTube, and VEA is a very good source for educational videos. They do lots of different ones, and if you go to YouTube, look under wound care nursing, it will come up as one of the main ones. So we'll talk about a bit of what was in the video as we go through the next part of the tutorial. So, what is wound care? And it's us providing the appropriate environment for healing, both indirect and indirect methods, together with the prevention of skin breakdown. So, we give it the optimal environment to get the best repair we can in the space of time we have in a hospital. And as you know, stays are shorter in hospital. We have to try and get that improvement going as quickly as we can to get the patient home so they can keep on having that improvement. And a lot of home care, home services now have wound nurses that go around with them. So, and wound, I can go into wound dressings, but they are such a specialised thing and they are changing all the time. But we will talk about later on about general wound dressings. The little picture there is actually a good demonstration. So on the 7th of the 5th, that's what they had. So cracked heels, probably a diabetic. Here on the 18th of the 7th, that's with the proper treatment, it's come down to this. And there we go on the 1st to the 8th, they're virtually healed. They've still got the swollen feet, but what a big improvement. And that's all about the right care, the right dressing, optimal. It takes time though. You will not get healing in 2 days or 4 days. It does most wounds, and the older you are, the longer it takes. So it can be 3 to 6 months, it can be years, but still the same aim is to get that healed. And having wound specialists, you'll find that that will happen a lot better. Okay, so what causes wounds? And the video talked a bit about different types of wounds. Trauma, right? So it can be sharp, it can be a stabbing, a laceration, a cut, right? Such as a stab wound, or a blunt, hit with a baseball bat, right? Crushing injury, right? Because what happens is, you crush something, bone breaks, pokes through the skin, you've got yourself a wound, right? So blunt force trauma. And of course we get surgical wounds, deliberate ones, nice straight lines that are cut and hopefully heal beautifully. We get burns, again another type of wound. They can be small or large, right? And they can be at different depths burns. So you can get 1st degree, 2nd degree and 3rd degree burns. So all have different materials to help them heal, all take longer. And all have different levels of pain. And we have chronic wounds, such as ulcers. So pressure ulcers, venous ulcers. So we have to be aware that there are all different sources in them, but that all comes down to a break in the skin integrity is a wound. So the skin. Now I didn't know that it was 16% of our body weight. So all I tell people now is I've got heavy skin. So the skin's the largest organ in our body. That's a good Trivial Pursuit question. It is 16% of our body weight. And it has lots of different functions, right? So, and they're vital functions, right? So, it includes keeps our immune system. So, it helps process vitamin D, helps build our immune system from the sunlight. Temperature regulation. So, how do we regulate our temperature?
Your blood vessels near the surface or away from the surface if you've got a cold.
Yep. And it also, we shiver.
Sweat.
Yep, and sweat. Absolutely. So, they're all things that help regulate our temperature, and that's what the skin does. Okay, it's a dynamic organ, right? It's in a constant state of change. As you know, we rub our hands, we lose skin cells. Right? And they're automatically replaced by inner cells moving up from the surface. And we'll talk about the layers of the skin in a moment. And where the cells come up through the hypodermis up through to your epidermis. So you're getting nice fresh skin cells all the time. So in other words, our skin, right, keeps harmful substances out, water and electrolytes in. Right? It protects our internal structures and organs. Acts as a gland for vitamin D synthesis. Huge epidemic throughout the world now with people with lack of vitamin D, particularly in first world countries, because a lot of time spent inside or in big cities in the shadows. And vitamin D has become a huge issue, and they're still looking at the long-term effects of vitamin D, because vitamin D comes from exposure of your skin to sunlight.
I think it's school children in Australia as well, because it's this slip, slop, slap. They've gone so far that the children aren't being exposed to the sun when they grow.
You need actual direct sunlight on your skin for around 20 minutes a
Yeah.
day.
So we're currently reviewing a lot of those things now as to why zero vitamin D. And it's a sensory role, obviously. You know, it's got our little nerve ending in there so we can touch, feel, all that sort of thing. And as I mentioned, it regulates our body temperature by sweating, by shivering, by vasodilation and vasoconstriction to the surface. So, the skin obviously comes in three main layers. Right, so we have the hypodermis down here, which sits just above your part of your adipose layer. We'll talk about it in a minute. Dermis and the epidermis. So hypodermis, dermis, epidermis. So the epidermis, the outer layer of our skin. Right? It's our epithelial cells, our skin cells. It's an avascular. What does avascular mean? What does vascular mean then? Close. Cardiovascular. So vascular is about blood flow. Blood supply through veins, arteries, capillaries. Cardiovascular system. So if it's avascular, it means it doesn't really have a blood supply, direct blood supply. And it's about 0.4 millimetres thick. That's your outer layer of skin. Only thin. And it regenerates every 2 to 4 weeks. Nice new skill, so you're young again every 2 to 4 weeks. Better than the facelift. Receives nutrients from the dermis, which is the one layer underneath it, as we saw in our picture. And it's comprised of 4 to 5 layers, depending on the body location. So you can imagine over areas that it needs a stronger protection, there would be more layers of skin. And if we're close to our bone, it would probably be less layers of skin. So the dermis, that's the middle layer. Right? The middle layer. So epidermis, dermis. And it's about 0.5 of a millimetre, half a millimetre thick. So the epidermis is 0.04, so it's really thin. This is a bit thicker. Right? Subject to the anatomical site. So obviously it gets a bit thicker, that's why there's thick skin. Nothing to do with the fat underneath its thick skin.
Works for me.
It's very vascular. That's when we cut ourselves. It's not the epidermis that bleeds, it's the dermis. That's where you get your flushing. It's not the top layer of skin that's actually changing, it's the underneath layer showing through that very thin layer.
So is that why sometimes whenever you get, if you cut it, it's just like a cut, like...
Yeah, and you see just a red mark there.
Yeah.
Yeah.
And it's actually...
It's not deep enough, it's a very shallow, fine cut.
45 degrees.
Yeah, and you see ladies that have skin tears, they don't always bleed. And you'll see the pink underneath it.
Oh, is that why, like when you say, like I've hit my shin and stuff before,
Yep.
and it hasn't actually bled, but
Bled.
it's like you've sheared,
Yeah, you've what they call degloving. You've taken the skin off it.
so the top bit
Yeah, so that's your top layer. It's like peeling off that glove, and underneath,
is like the white.
yeah, that's where your bleeding will occur if you go through that.
Oh, okay.
So it contains nerves, connective tissue. So that's why your outer layer, we can feel things because the nerves are up under, it's only 0.4 of a millimetre. So, and all the specialised fibroblasts and mast cells that help with our immunity live in our dermis. Responsible for inflammatory reactions which occur in response to trauma or infection. That's where we get our swelling from. We get the fluid leakage comes up through our dermis. And receptors for heat, cold, pain, pressure, itch and tickle. So that's where all those little nerve receptors sit. So we go down to our hypodermis, which in our 3-layer structure is the lowest layer. That's the one above your adipose, your fat. The hypodermis is the innermost layer of the skin and is referred to as the subcutaneous layer.
Is that the
So, what was that?
It's where we put our needles.
Exactly, that's what we're going for when we put our needle in, is our subcutaneous injection. So it goes into the subcutaneous, or the hypodermis.
Oh, so is that either name?
That's why they call it a hypodermic.
A hypodermis
Yeah.
is just the other name for
It's
it.
a subcutaneous.
It is a subcutaneous layer.
So Neville, that's where all the needles go, is it? That's what you've got to aim.
That's subcutaneous needles. If you're giving an intramuscular, it's going into the muscle which is below, which is below you, underneath your hypodermis or subcutaneous
That's why
layer.
you use the
Yes, thank
longer
you.
needles.
Yeah,
Yeah,
thank you.
that's all right.
You don't go on the angle.
So this one supports the dermis and the epidermis. It gives us our little bit of bounce back. Right? It varies in thickness and depth. Again, thick skin, what can we say? Comprised of adipose tissue. You know what adipose tissue is? Fat.
Oh,
That's its proper name, the adipose tissue. Any Doctor Who fans? Remember little fat characters on Doctor Who were called the adipose. Connective tissue and blood vessels. So what's connective tissue?
Oh,
you like bones?
It has sinews, muscles.
Tendons and
Connective tissues can be bones to a certain extent. They still connect up. Muscles,
Muscles, yes.
all those sorts of things can be in that layer. Right? And of course blood vessels. It's a very vascular place as well as your dermis. Because your skin cells start to generate in your hypodermis, go up into your dermis and pushed up to your epidermis. That's how you get that 2 to 4 week replacement of your skin cells. Functions to store lipids. Another name for lipids. Fats. Protect the underlying organs. So our fat layer, that's why we've all got a little bit of fat on there. It's protecting our underlying organs. I'm not just overweight because I overeat, it's protecting those organs.
I can't.
And it provides insulation and regulates temperature. That's why I'm a bit fat too, because it's winter and I put on my weight.
Okay.
I'm sticking to that excuse. It's good, isn't it?
well, that's your excuse and you're sticking to it.
Yep, my word.
So does that mean that your organs must get bigger when you get older?
Yeah, that's it.
Need more fat.
Yeah, that's
Because
it.
the organs got bigger.
They need to be happier and warmer. So, wound staging. So we've talked about the skin and that in the case of the skin, a wound is where we break make a break in our skin through our epidermal layers or our hypodermis. So they come in different stages, and it talks about, get out of that light. So stage 1, we mentioned that's that layer of skin, the epidermis, right? It's up on the epidermis, right? So it can be non-blanchable. You know what the term blanchable means, or blanching.
Is that white? Is that it's white? Does it go red or something? Is that
when you press something that on skin? When we're talking about skin,
yeah.
If you press your skin, it goes white.
Yeah.
That's where it blanches and it goes red again.
Yeah.
So if it's non-blanching, if you were to touch that sort of wound, it wouldn't go white. It would stay pink.
Oh, okay.
Oh,
Because
yeah.
everything is redness.
So the bit that goes white is gone off it. So it's that first layer.
Okay.
Okay? So erythema of intact skin.
Redness.
So erythema is like redness, right? Irritation. I flashed my leg to show you what erythema is, but it's probably not appropriate. I have erythema because I'm a diabetic on my lower leg. That's common with diabetics, and you'll see it's red, it's irritated, but in a lot of cases it doesn't mean, or it does mean it to the person, I suppose. I don't go and flash my legs on the beach anymore. But it means that, in that respect, that it's still a non-blanching redness there, and it just doesn't look nice.
So it's just red.
Yeah, just red, and it looks irritated, but it's not. Don't even notice it.
Does sunlight help that sort of thing?
The problem with it is that your skin's more susceptible to getting burnt if you expose it to it too much. So stage 2, superficial skin loss only. So you get a blister from a burn. That's a stage 2. You've got that fluid build up, you lose your skin. So it takes away that first layer, you've got all your nice fluid build up. So it's going through the layers into your, what do I call it? Epidermis, into your dermis. Okay, so stage 3, that's with the loss of tissue, with a cavity involving subcutaneous tissue. So, what do we say was in the subcutaneous tissue?
Muscles.
Yeah, connective tissue. So muscles, so it's eaten into the muscle or eaten into a tendon or something like that. You'll see them. And often when you see a big nasty wound here and you look into it, you'll see the white tendons where they are because it's eaten around the skin, you'll see tendons that move inside the wound. So stage 4, the loss of tissue, and the cavity extends into muscle and bone. So not just only is it those subcutaneous, and it can be a little bit of the muscle, but it extends right into the muscle. It's eating away. So these are considered very, very serious when they get to this stage. So you're 3 and 4. So stage 1, as we mentioned, not really a loss of skin, but there's a redness there, an erythema. Stage 2, we've lost a bit of our epidermis. Stage 3, you can see we've gone down into our dermis. And if you have a look, there's our subcutaneous layer here. So we've eaten into that, haven't we? And we're starting to get into some of the soft tissue. Right? Stage 4, we've eaten right down into that soft tissue, the muscle. We can see bone quite often. Stage 4, you'll see bone, you'll see sinews, you'll see tendons, everything. You can see them move when they move their hands. So you can imagine that's 3 and 4, we're talking really, really
I've
serious.
seen one of the stage 4s.
Yeah,
That's huge.
yep,
And
absolutely.
so how do they get that bad though?
And we'll talk about it in a minute, but sometimes it starts out as, one of the biggest examples and the most common examples is pressure area. someone's laying in bed for an extended period of time, they don't get out of bed, they get a redness on their bottom, they get an erythema, non-blanching redness.
So that's why you
People ignore it. It's alright, don't need to worry about that, it's only just a red patch. Particularly if they're paraplegics or quads. So you'll get a redness develop and they'll ignore it. So then if the skin breaks down a little bit more because the pressure's maintained and you get a bug in there. So whatever that bug may be, and they start to eat away at the tissue underneath and the tissue starts to die off and it just simply erodes away. And if they have nice early intervention, it can prevent that. But if it's ignored for whatever reason, and there's lots of reasons why, family don't recognise it, people hide it. I always talk about a man I looked after when I was in Melbourne, and he came into ED, and I was actually working as a wardsman at the time in ED. And a man came in and said, "Look, can you help me get my dad out of the car? I'm really worried about him. He seems quite unwell, he's got a high temperature." All right, no worries. We went out, we got him, we went to lift him onto a trolley, and I thought, gee, he's skinny, I can feel his bone. When I was lifting his legs, we got him onto the trolley, he was covered in a blanket, took him inside, the nurse pulled down his blanket, and all that basically was there was the bone. His whole calf and right up just below his knee had all been eaten away. There was a little bit of skin on the front, and that was filled with maggots.
You're kidding.
No, the maggots are what saved his life because they're already all the dead tissue. But what we asked when they inquired, and I hung around to find out what had happened, I was a bit shocked. And the son in their country, if someone's sick, you leave them in bed, and you do what he was the patriarch of the family. If he said, "I stay in bed and I keep the covers open," that's what happens. He was embarrassed because he was a bit incontinent, so he laid in his own urine because he was embarrassed and he didn't want to be seen as weak in front of all the other family members. He'd been like it for a month in bed.
In a wet, yucky bed.
Well, they changed the sheets every so often when they got him out of bed and sat him out, but he wouldn't uncover himself. They put him straight back to bed because that's what he wanted. And this pressure area developed over a week or so. And they didn't realise until one of the children insisted that they clean him up.
Could it only take a week?
But it doesn't take very long, does it, to break down?
Once that bugs are in there and they're doing the destructive thing, it chewed all this away. That was the story we were told. So, for whatever reason, they can get that way. It happens sometimes in hospitals where poor care, staff don't look for it, and therefore they ignore what they see. They don't do proper turns. They don't, gets too busy. You can't do your 2-hourly turns. The wardy was busy. I forgot about the man. He lays there for 8 hours and not been turned. And it starts to develop. He's got a poor immune system. He's a diabetic or he's been on chemo. He's got a poor immune system. Those bugs get rampant and just start to get into that wound. Better management probably would have prevented it, but...
So is it always like so what sort of bugs, like just disease bugs?
It can be your skin, like the simple
Germs.
Staph aureus is a common one.
Yeah,
it's on your skin all the time, golden staph. Can get in there and you get staph infected wound. Multiple MRSAs common in wounds. Multiple resistant Staph aureus. That's ones you can't kill with antibiotics. So you get some really nasty bugs in there.
What about necrotizing fasciitis? Is that one that's on the skin, or is that only in a wound from surgery? How do they contract that?
Again, that can come from you have a surgical wound, or you get a breakdown in the skin, and the bugs from your external skin, whatever they may be, or It might be someone checking that wound, not washing their hands properly. It gets into the wound and it gets under the skin. It gets through that surgical wound. So it doesn't eat its way down. It starts really low down in the subcutaneous layer. And so you won't see it because it'll be underneath. By that stage, it's got necrotic tissue in it. And we'll talk about the colours in a minute. It gets necrotic tissue. And so then they've got to open it up. And they've got to clean it out.
You basically got to remove it with surgery because I don't think anything kills it, does it?
No,
It does. You can treat it and you can grow it back and kill the bugs depending on what the bug is.
What is it?
You can get necrotizing fasciitis.
That's
So necrotic destruction of the fascia.
Death
Basically,
when it dies.
your skin and flesh dies.
Yep, it chews away.
Oh,
A bit
that's
like
bad.
gangrene, if you want to think of a simple thing,
It is.
gangrene type thing.
Is it flesh eating?
Yep.
Mike's mate went over to Thailand.
Yep.
And yeah, he
It's very common in
lost
tropical
bits.
countries.
Yeah, because it was a flesh eating one, and if they hadn't have got him to hospital here, he would have actually died.
Yep.
Because and he lost bits and pieces, and then it sort of came back. He cut himself on an oyster shell or something, and it must have still
Yep, still
had
was
it
sitting
in
there.
his system, and he's lost one of his toes now.
Yep, sad, isn't
So,
it? So, we're going to talk about ulcers, but this applies to any type of wound, right? But pressure ulcers are the big thing these days. And we've just talked about how we get them and where they come from. In hospitals, if a patient comes into an emergency department and they have a pressure ulcer, they're required to record it or they're fine. The hospital is fine. And now they have pressure audits every year. Basically every patient in the hospital is inspected for pressure areas and it's recorded, and they look at whether they're getting increasing, decreasing, what wards have pressure area issues, what they can do to combat that. But if it goes unidentified, the hospital's then blamed and fined, and they have to keep that patient in longer as well. So they may say get a $10,000 fine from the health department, but then they've got to keep that patient in for say 5 or 6 days on antibiotics. There's more thousands of dollars spent. They could cost them $30,000, $40,000. So you can imagine they're hyper vigilant about pressure area now in most places. And when they come into emergency, we do a quick scan of them, a quick assessment of them, to make sure they don't have pressure areas, particularly if they're in a group that's high risk. So someone who's a quadriplegic or a paraplegic or someone with an illness that affects their immune system, someone who's elderly. So it covers a lot of people that come into EDs. And it's a quick survey over, you see a red area, you note it, and you organise treatment for it.
so on the little diagram, you just
Yep, they'll mark those areas off, and they do a pressure care assessment before they admit them to the ward. And that's in most hospitals. Aged care a bit different, but so stage 1, it's an observable area of redness. You get that nice red spot. All right. There's a difference or consistency compared to the adjacent skin. So you'll see a nice clearly red erythema-y mark on there. Right? Persistent even though the pressure is removed. So that non-blanchable. And it stays there even after we've taken whatever, where they were laying, we roll them over to the other side, we come back a couple of hours later and it's still red. That's a good indicator. And that's what it can look like.
So that can be reversed if it's that stage and you take the pressure off it. It will reverse fairly quickly. Or
It can reverse fairly quickly, and they don't normally, it's a bit of a massage or they rub something into it depending on where you are, and they keep the circulation back to it, it comes back. If it's not, there's not an underlying problem. So most of those are recoverable. So stage 2, so they're partial thickness. Skin's lost, bulbs the epidermis or the dermis. It'll be a little bit deeper, right? So we're talking about our burns and our blisters. superficial and presents clinically as an abrasion, blister, or a shallow crater. So a scooping injury. And there he is. So that's, you can see it's only through the first few, say, 0.5 millimetre at the most. Not very deep, but you can clearly see a break in the skin.
So how long would that then from that point take to get to a stage 4, do you think, if it wasn't treated?
Depends on the person. Depends on their underlying etiology, what was caused it, what is their health risks. Diabetic, it'll be faster because you've got slight immune suppression. Someone who's on chemotherapy, they're immune suppressed, so it'll be faster. It could be days or it could be months. Depends on if they've got poor nutrition, poor health.
So how do you fix that one then, Nev? Like,
That would be treatment, and I'll talk about treatments shortly down the track. But they would start treating that with a dressing of some kind. But normally we use one of the, because it's not got exudate, and we'll explain exudate shortly, you would cover it with a moist dressing. It depends on the wound care nurse, and there's lots of different ones. And they put it's like a clear dressing over the top, which has a bit of fluid in it, which helps heal that sort of surface wound.
so you wouldn't then obviously put them on that side, would you?
No,
They'd have to
you'd stay well away from that. You wouldn't want to
stay
risk
off
it.
that side.
They use ones with padding on them, so you can switch them side to side a bit, but you'd probably leave them less on that side where the skin breakdown was, or make sure it's well protected. So that's it again. Closer. So, pressure ulcer stage 3, full thickness involving loss, damage or necrosis of the subcutaneous tissue. They may extend down through the underlying fascia. We mentioned fasciitis. The underlying fascia presents clinically as a deep crater. So it's going through those layers. It's down right, we're not right down into the hypodermis now. Potentially. That sort of thing. And you can see there's some slough, is the term they use. I call it slough.
So do I. Slough.
Yeah.
Is it like pasta?
It basically is a type of pus, yeah. That's probably the more common term you'll hear.
So that would be cleaned out when they're cleaning the wound to
Yep.
get rid of it, wouldn't it?
Yep.
Yeah, the lady that had the hole, it just got a little bit of whitey like that,
Yep.
and you just got to
Give it a sweep through,
yeah.
and you won't get rid of it all, but you'll keep any excess out. You get that exudate out. And sometimes it can be a matter of covering with the right dressing that sucks all the exudate out. We'll talk about that as we go along.
Is that too where they like pack them a bit?
Packing's a lot deeper than that normally stage 4. So full thickness skin loss with extensive destruction of tissue. So you get necrotic tissue. Right? Remember they talked on the video about black tissue, that's necrotic tissue. Or damage to the muscle or bone supporting the structures. So you could be chewing into a tendon or a joint. Right? So there's risk to those structures. So we're looking at this sort of thing.
Is that the bone? That's on the heel, is it? On the
Yeah,
foot?
it is a heel.
And an
Is that the
ankle.
bone, that red thing?
No, that's granulating tissue.
Oh, okay.
And a bit of slough around the edge, but that's good tissue in there. The bone, you'll see, is very white.
White. Oh,
They
okay.
stand out really well. Tendons and bones, when you see them, you'll see them very clearly.
So tendons are white too, aren't
Yeah,
they?
you'll see a white tendon or a whitish yellow.
Oh, yeah.
So, factors that affect our skin integrity, right? So, immobility and inactivity. So the little people who've got the arthritis that can't get out of their chairs very easily. Or they're stuck in hospital and we keep them in bed. Okay, restlessness, so that moving around, you get friction. You're moving all the time, break down your skin. Sedation. Doesn't put our skin to sleep, does it?
Puts
No.
you to sleep.
Puts us to sleep, and you lay there and you don't move. Right? You get no movement at all. So you have to make sure we roll those people if they're sedated. Poor nutrition. Okay, we're not eating all those vitamin things that keep our skin healthy, so it will break down a lot easier. Poor circulation and oxygenation. Fair enough. You don't get a nice blood supply to our skin. Absence or excessive moisture. So dry skin will crack and open up. Overly moist skin will macerate, which will chew up, and you'll get
We've got rats in our roof.
you'll get a breakdown of the skin from the skin maceration where it's all broken down because it's too wet. So what would you imagine one of the big things that would be caused by?
Is that like when the ladies have like big breasts and stuff and
Yeah, and they sweat underneath. Yep.
A few of them had.
And incontinence. The incontinence pad's kept on for too long. It's wet. It breaks down the skin in the groin, on their buttocks.
Well, it's like a bit nappy, hey?
Yeah. And of course, neurological issues. So you don't have any feeling, so you can't feel the pressure if you're a paraplegic, a quadriplegic, or people with MS. They don't have any sensation, so you won't feel it. Diabetics with peripheral neuropathy is another one.
It's the same with emphysema, effects of smoking. My dad's got his feet are cold.
So that'd come under there.
Yeah.
Poor circulation, no oxygenation because his lungs aren't working properly, are they?
Yeah.
So he's not getting that oxygen to keep that skin nice and healthy. So, factors that affect healing. So we've looked at what is a risk to our skin. So, what are the things that can affect our healing? So the temperature will affect healing, and we'll talk a bit more about that in a minute. Exudate, ooze, slough, pus. Sounds like it, yeah.
Weeping, because sometimes that's that.
Weeping, there's another good one. Age will affect how we repair. How good is our skin? How much do we improve, you know? The underlying diseases, we've mentioned diabetes, respiratory conditions, can all affect that. The vascularity, we mentioned what vascular was before, avascular and vascular. So how much blood flow to that skin.
So that's why diabetics are worse.
Yeah, because some diabetics get reduced blood supply, and some get peripheral neuropathy, so the nerves die off, so you can't feel. You might have a good blood supply, but if you can't feel it because you've got no sensation, you can step on something, put a hole in your foot, and off you go.
Yeah, that's me.
People have lost feet from that, lost legs.
Can't you feel too?
Not my feet.
So, size, obesity, poor sensation and movement. Again, here comes our diabetics or our elderly with their arthritis that can't move a lot. Radiation. Breakdown from heat, radiating heat. And what medications you're on. So radiation treatment as well. So radioactive treatments. So chemo. Radioisotopes you put in the spot. They break it down. Drugs. Medications that you're on. Methotrexate's one drug that they give you for arthritis, but it also can affect your skin. So,
long-term use of steroids too.
Absolutely.
Doesn't it?
Yep, absolutely. They get that paper skin that tears so easily. So, factors that have continued. PVD, peripheral vascular disease. Basically, that's what your dad's got.
Yeah.
Again, we've talked about age, obesity, friction and shearing forces. We put them in the bed and we drag them up the bed without the use of a slide sheet. It rips their feet away. You can pull their skin off. You can deglove someone's ankles. Surgical intervention. We cut a hole in there, there's a risk. Infection, so course, common sense, it'll break it down. You can get gangrene, you can get all that sort of thing. Systemic disorders, diabetes again, those sorts of issues. Diabetes, it says underneath. And the autoimmune disorders, arthritis, eczema, all break down your skin. So, how do we assess a wound? How do we decide, is this wound something we should be dealing with? Well, we should deal with most wounds. But then we're going to need to describe the wound so everybody understands what we're talking about, and they don't have to go and lift the patient's blankets every time to have a look. So the wound etiology, and we'll go through this shortly, there's a bit of more explanation. Wound location, wound size, wound bed, we'll talk about that a bit more. The wound edges, so is it a straight or a jagged wound edge? Wound drainage, what's coming out? And if it's a perioperative wound, post-operative, do we have to work on it? So etiology, how did it happen? What caused your wound? And they call it mechanism of injury. Right? So, how did she sustain the head injury? Right? Lady falls. Why did she fall? I've had it happen to me. I had a man came in, he'd broken both, he had bilateral calcaneal fracture, so he fractured both his heels. He was up on a ladder, he was 78, climbed up the ladder to clean out the gutters, because the wife nagged him to do it. That's what he told us. Of course, women don't nag, I wouldn't dare say that, because there's 4 women here and I'm a coward. She nagged him to clean out the gutters. He fell from the ladder. I had a very junior nurse at the time there, and they were really concerned about the fracture. And I said to him, we need to do an ECG on this man. And he goes, why? He's got fractured calcaneal. I said, I know that. But I had a hell of a time explaining why I wanted an ECG. Why do you think I would want an ECG on that man?
In case he had a heart attack.
How did he fall? He's normally active, alert, can climb up the ladder all the time. Why did he fall off? He hadn't had a heart attack. I was still a precaution. But that nurse went, see, I told you hadn't had a heart attack. I said, but how did you know that before we did the ECG? Sometimes we have to follow up. What we did discover is that he had a TIA. He'd had a little mini stroke and he just lost his balance and gone straight down. But we could then tell him, please don't go up the ladder again. You know, get someone in to do it for you.
My dad did that.
Yeah, a lot of oldies are like that.
Focus palm. He was probably in his late, probably 60. And
Yep.
he was cutting it and fell and crushed his whole foot.
Yeah. They do it. So we want to know how long it's been there for. Why would we want to know how long a wound's been there for?
In case his skin dried.
Yep. If it's a fresh wound, we've got a quick chance we can clean it out and prevent infection. We might start them on antibiotics if it's been there for a couple of days, because the bugs from your skin have already got in there and started chewing away.
Would you do a swab on it if it was an older wound?
Yeah,
To
they
see
always
if there's
do,
any bacteria in it?
Yeah. They'll put them on a broad spectrum antibiotic, and then they'll do the swab, because they take a couple of days to come back because you have to culture them, and then they'll make a more specific antibiotic to that particular bug. So, wound location. Right, we need to use our anatomical term. So, is it dorsal, proximal, distal, when we locate it in a set of nerves? It gives us an insight to the type of wound, pressure ulcers. So, if we describe it as being down on the back somewhere, right, we could be talking about the buttocks, couldn't we? People give strange general descriptions, particularly people who don't know the terminology. It's down on their back somewhere, and it'll be down on their buttocks, and they've been laying in bed for a while. We can look at it and say, okay, that's a pressure area, we need to deal with that this way. If the wound's in their lower back, well, how did they get one in their lower back? Did they lay on something? Were they stabbed? Were they cut? Okay? So peripheral wounds will be slower to heal. So shallow wounds actually start healing a little bit slower because they're more exposed. Things out on there because there's not a good blood supply. So wound size. It's our indicator that tells us if what we're doing is right. Are we improving it? Is the treatment we're giving working for this particular type of wound, or is there something that we're not taking into account? There could be an underlying infection that we're not seeing if it's not improving. Okay? So you want to get a good description of a wound, you want to measure the length, the depth and the width. Don't go poking a ruler in it.
Can't we?
No. It's an estimation of the depth. Surgeons can do it because they've got sterile instruments to measure it, but we shouldn't be poking the old wooden ruler in there. That's a mill. Pictures of wounds. Remember, you've got to get the patient's consent before you take photos of their wounds.
Oh, okay. Is that any photo at all as well?
Any photo of any patient, you want a signed consent form.
Signed consent. Oh, okay.
Yep.
Yeah.
Most places have photo consent forms. We even have them here at King's.
Okay.
And they need to sign it, say, look, we're going to put this on your history, it's going to go nowhere else. Or the doctor might say, I need to use this for teaching, are you happy? I'll get it to sign that. Okay? But it also gives us a good view of how that wound's progressing. Because a picture's worth 1,000 words, isn't it?
Yes.
And mark it with a pen. No pretty pictures of a little country scene. We mark around the edges of the red area of the wound, right? So we can see if it's going in, no ink into the wound, but just on the outer edges of it, around the reddened area. So not right on the edge of the wound, but so we can see if it's growing. It's another indicator if it's growing or shrinking.
What kind of pen do you use?
They have things called skin markers
Oh, yeah.
that they use in surgery. They cost about $50, and they're basically an indelible, non-erasable whiteboard marker. They just sell them for that because it's. So a lot of the doctors have their own ink pens that they use, and they do it in pre-op rather than wait till they get into surgery to have to use a more expensive marker.
Yeah, because you see them drawing before surgery, those purple pens. Is that what they are?
Yeah, that's all they are. Yeah, they'll draw it. If they're going to do, say, they're going to do a bit on their hip, they'll have arrows and it'll give them a direction. Neurosurgeons will mark out on the spine the location of where they're going to operate. And then they'll obviously paint all that, and then with iodine or whatever they use, and then they've got a good mark because they've then had the time to feel down. They'll recheck it,
Yeah.
and then they'll go in there. But they've already got that external guide. So the wound bed. So it reveals how it's progressing, the phases, the progression that it's making. So there are 5 main tissue colours. I think the video mentioned 4. They don't mention green. Pink, nice healthy pink tissue. That's that pink on the outside, it's nice. Red's that reddened area, and if it's an open wound, there's red in there, granulating tissue.
So is that a good thing or a bad thing?
Good thing. I'll show you in a minute when we get to our next slide.
Like-
Yellow, that's our slough pus. Black, necrosis. So that's where it's breaking down, the rotting tissue basically. And green,
That-
infected,
Pus, wouldn't it?
could be, it could be that we're getting gangrene. So we need to really monitor that. Let's go. So pink tissue is epithelial tissue. You mentioned epithelial skin, partial thickness wounds, right? So epithelial tissue is a pearly pink colour. Granulating tissue or red, you mentioned red before. Classical, shiny, beefy red. That nice bit of fresh beef that you get. Granulation tissue is a healthy sign. It's a good thing. And you don't want to, and that's why they don't clean wounds that have nice red bits in them, because you're taking away that nice granulating tissue.
Can it over-granulate?
Yeah, you can get over-granulation, you get what they call a granuloma.
And that's
It's
a bad thing?
over-granulation, and they'll cut that away, but they try to avoid that. And if you just clean it and keep it neat, you don't get over-granulation. And they use dressings and packings inside wounds to stop over-granulation.
Oh, okay.
So
yeah.
it presses up against it, so it granulates at the rate they want it to, then they close it over. But you can still get a granuloma underneath. Tissue that appears grey or purple indicates inadequate blood supply. So it might be red, but you might be having purple around the edges or a greying colour. You know that you need to consider blood supply, what's happening to that. So it's pretty important. The wound bed. So we're still on there. Yellow. The slough, slough, whatever you want to call it, pussy, tissue. Yellow or tan coloured. We could call it beige almost.
Oh.
No, please don't.
Stringy mucus material called slough. You saw it on the video where it was dripping out of the foot. So it is non-viable tissue, right, or yellow necrosis, breakdown. Black, necrotic tissue. So necrosis delays healing and is a focus of infection, and it's normally removed by debridement. But as RNs, we don't debride, we get a wound care nurse in to do that. So then they take the minimum amount, because we don't want to risk taking that nice red granulating tissue with it. So the wound care nurse will come in and start to debride. As ENs and RNs, you should never debride unless you've got the wound care nurse's permission or the doctor's permission, right, to make sure you're not interfering with what he wants out of his wound. I certainly don't want necrosis. And eschar, that's that black tissue. You'll hear that term eschar every so often. So green, infected tissue. Can be green or yellow. Infection occurs when an imbalance of normal flora, all that. So it's indicated by pain, edema, heat, erythema, exudate at the wound site, and an elevated temperature. And what's this one?
White blood cell count.
Yep. Why would that be up, do you think? What's white? What are white blood cells?
That's your immune system killing germs.
Yep. That's your immune system's response to eating those bugs, the phagocytosis, where they eat the other germs and the invaders into the area. If that's all up because your body's releasing more and more and more to try and kill them off, sign's a good sign, a good chance you've got infection in that wound. And if you've got all that debris in there and all that stuff, you can't really gauge the depth. You can't put something in there and prod and poke because you can't see the bottom of the wound. So the wound bed, exudate, right? There's different types of exudate. So it doesn't always mean it's sloughy. So serous, it's clear and straw coloured. That's a good sign that it's healing.
That's mostly burns, isn't it?
No, you'll see it in ordinary wounds as well. Once you've cleaned them, there's no infection in them, they'll get a straw coloured ooze come out of it, which is okay. Hemoserous, slight blood. It's not a bad thing, but you've got to think, well, why is there getting a bit of bleeding into it? It could be that the tissue's granulating well, but they'll keep a closer eye on it. Sanguinous, heavy blood stain. Exsanguination is where someone bleeds heavily. So heavy blood stain, sanguinous exudate. And purulent, pus-laden, infected, normally smelly. So we'd be really worried. Either of those, you want to be getting someone to look at them. Why is it bleeding? Why have we got this? Are we on the wrong antibiotic? What do we need to improve? So the wound bed temperature is important.